let's go through it. So first of all, I'm going to talk about why and when we might need to do a neuro assessment. Thank you everyone for the thumbs up, much appreciated. Right, so here at Clinical Physio, we have a phrase that we use, or a little sentence that you can use to try and remember when to do a neuro assessment. The sentence or the line that we use is: always above and below, consider spreading and neuro. So that's the first thing I'm going to ask you to write down tonight. Always above and below, consider spreading and neuro. Okay, and I'll take you through what that means. So always above and below means that whatever joint your patient has their pain, you're going to double check the joint above it and the joint below it to go through either active range of movement with overpressure or passive range of movement with overpressure of the joints above and below to help you rule in or rule out whether there's a different joint that's at play for your patient's symptoms. Okay, that's always above and below. Consider spreading and neuro, and that's obviously what we're all here to talk about tonight. So spreading. So we're looking there for if your patient presents with pain, that spreads peripherally, okay? And when we say spreading, for the upper limb, we're talking about pain that spreads down and past the elbow. So down and past the elbow distally towards the hand. Or for the lower limb, just because we're on the subject, spreading down and past the knee. All right. So for example, if you had a patient with neck pain that only stopped here, they had absolutely nothing towards the rest of the hand, I would not consider that you absolutely need to do a neuro assessment on that basis alone. However, if they had pain at the neck or the shoulder and it ran down and past the elbow, if it was spreading in that region, then the answer is yes. Okay, so in terms of consider spreading and neuro, that's the spreading, down and past the elbow. So when we say neuro in that phrase, consider spreading and neuro, we're talking about neurological symptoms. Okay, so they might include pins and needles in the upper limb, numbness in the upper limb, weakness, which is a pretty big one. So if they're reporting widespread weakness that goes into the hand or into the elbow, and I suppose the idea with weakness is that you're not just talking about it doesn't feel like I can push I can't, throw a ball quite as firmly as I can with my other hand. We're talking about distinct weakness that might imply a neurological condition. So we're talking about dropping things with their hand. We're talking about not being able to push a door open. Whereas the other hand can easily do it. We're talking about dropping plates, for example. That's one that you'll commonly see. Or even just to the extent that you might see with some patients that they might present with this kind of position. And you say, okay, can you open your hand up? And they say, actually, no, I can't. Or can you make a fist? And they're kind of like, well, no, I can't really control that. That's the kind of weakness that we're talking about. Okay, so pins and needles, numbness, weakness, and also red flag pathology. So that could include VBI for the neck, which stands for vertebrobacillar insufficiency, which is an obstruction or a restriction in the blood flow which is going up towards the brain. We're also talking about other red flags such as cervical artery dysfunction. We're talking about potential signs of an upper motor neuron lesion. So that might be things like tripping up, feeling poorly coordinated. Those are potential signs of an upper motor neurological condition, or something horrible like cancer. All right, or something like a stroke. Okay, so those are some examples of red flags. So in answer to the question from today, on the quiz question today, the first half of it is, the answer is consider spreading and neuro. So in terms of the spreading, you're looking for pain that runs down and past the elbow. And the neuro aspect of it, I'll just say that one more time. Examples being pins and needles, numbness, weakness in the hand or the upper limb, red flag pathology such as VBI, cervical artery dysfunction, upper motor neuron lesions. Okay, so there's plenty of examples there for why you might have your three symptoms that might provoke you to think that your patient needs a neuro assessment. So I hope that makes sense for the first part of things, why we actually do it. There's your answer. Okay, if you want to run through that again, if you go to our... I'll tell you about that in a minute, where to go to. Just write down for a second if I need to look at this further, and I'll tell you the answer in a minute. Right, so now let's go into your neurological assessment. So there are effectively 5 things that make up a upper limb neurological assessment. The first one is a range of movement test of the most closest spinal junction. So that would be the neck. All right, so you need to look at your active range of movement or passive range of movement with overpressure of the neck or the cervical spine. Okay, so that's number 1. Pretty easy to do that. Next, we have myotomes. So this is going to be, I'll mention the 5 of them. So that's the first one. Then you've got myotomal testing, which we'll go through, of course. You've got dermatomal testing. We've got reflex tests, and we've got upper limb tension tests. Okay, so I'll say that one more time. The 5 key components of your upper limb neurological assessment: cervical spine, active range of movement; myotomal testing of the upper limb; dermatomal testing of the upper limb; reflex tests of the upper limb; and upper limb tension tests. And we'll go through all of them tonight. So, myotomes. So, we're looking at the myotomes from C1 to T1. All right, and I'm going to go through them with you. So C1 is for cervical flexion. All right, so you're putting your hand on the front and asking your patient to push down. So C1, cervical spine flexion. C2, cervical spine extension. So you can do that with one hand behind the head and then pushing backwards. All right, and C1 and C2, there's no right or left bias. There's no kind of down to one side and then flexing or extending. You're just looking at pure, can they do the movement, and that infers for both sides. So that's C1 and C2. C3 is side flexion. Now, and all of them from C3 to T1, we're going to test on both sides. So C3 is cervical spine side flexion or lateral flexion. All right, which you're testing like so. C4 is shoulder girdle elevation. All right, not shoulder elevation, because that would be that. Shoulder girdle elevation. That's C4. C5 is shoulder or glenohumeral abduction. Okay, that's C5, shoulder or glenohumeral abduction. C6 is elbow flexion. Okay, C6, elbow flexion. C7, elbow extension. C7, elbow extension. C8 is thumb extension, or the thumbs up. So that's C8, thumb extension. And T1 is finger abduction and adduction. Okay, so you can look at both of those, abduction and adduction. Okay. Now I'm gonna bring this in right now. So I'd like you to, I'm sure lots of you are probably aware of this, but I'd like you to write down the following: www.clinicalphysio.com. All right, I'm sure that most of you are aware of the website, but once again, www.clinicalphysio.com. From there, when you go to the website, you can go to videos, and then you'll find that there's different for every single joint: cervical spine, thoracic spine, lumbar spine, shoulder, elbow, wrist, knee, hip, ankle, the works. Okay? And the reason I'm telling you this now is because we have detailed videos on all of what we're going through tonight. We've got detailed videos on all of it if you want to look at it again. So I've just run through the myotomes, but if you didn't quite catch it, or if you want to have a look at the handling in more particular detail, it's on there. Okay? The best way to find all the videos for tonight is you go onto www.clinicalphysio.com, go to videos, and then for today, I'd like you to go down to cervical spine. All right, so if you can do that now. clinicalphysio.com, videos, drop-down menu, cervical spine. And it's got them all there, including you'll see on there, upper limb myotomes. So you can have a look at those again if you want to. Right, now I'm going to actually get you to watch a video. It's because genuinely the best way of me teaching you dermatomes tonight, is to ask you to watch this video. It's going to be so much more beneficial than me trying to go through it on an Instagram live when I haven't got much space and I haven't got a model next to me.
So now we're going to take you through the dermatomal regions of the upper limb and the neck and head. What we're going to start with doing is go through these in detail, and then we'll go through them more quickly later on in the video. So we're going to take you through C2 to T1. Starting with C2. The C2 dermatome covers the posterior aspect of the head in a C shape, and it goes from one ear posteriorly round to the other ear. So C2 from one ear in a C shape posteriorly and round to the other ear. C3 is in a ring from the lower half of the anterior neck round through the posterior neck and coming back round the other side back to the anterior neck. So just one more time. A ring shape from the lower cervical spine, from the anterior, all the way around the posterior and back again to the other side. C4 is from the medial clavicle directly across to the ACJ, the acromioclavicular joint. So once again for C4, medial clavicle directly across to the ACJ. Next is C5. And the way you can always remember your C5 is 1/3 to 1/3. So C5 is from 1/3 down the lateral humerus, going down the lateral side of the arm to 1/3 down the radial side of the forearm. So C5, 1/3 to 1/3. 1/3 of the way down the lateral humerus to 1/3 of the way down the radial side of the forearm. C6. C6 goes in a direct line from the anterior shoulder down to the base of the thumb. So a direct line from the anterior shoulder to the base of the thumb and then into the thumb, both anteriorly and posteriorly. So one more time, C6, anterior shoulder, direct line through the arm to the base of the thumb and then running into the anterior thumb and also into the posterior side of the thumb as well. C7. C7 is a smaller dermatomal region from the center of the palm through to the second, third, and fourth digits anteriorly, as well as on the dorsum of the hand, from the center of the palm, as it were, to the second, third, and fourth digits. C8, from the ulnar styloid directly across to the tip of the fifth digit. One more time for C8, ulnar styloid, across the lateral hand to the tip of the fifth digit. Now, if you remember previously, C5 was 1/3 to 1/3. T1 is 2/3 to 2/3. So for T1, 2/3 of the way down the medial aspect of the humerus, running across the ulnar side of the forearm, 2/3 of the way down. So T1, 2/3 to 2/3. 2/3 of the way down the medial humerus to 2/3 of the way down the ulnar aspect of the forearm. And those are the dermatomes. We're going to run through them one more time quickly, starting with C2. C2, C shape, one ear posteriorly round to the other. C3, a ring from the lower cervical spine round to the posterior aspect and back round again to the anterior. C4, medial aspect of the clavicle across to the ACJ. C5, 1/3 to 1/3. 1/3 of the way down the lateral humerus to 1/3 of the way down the radial aspect of the forearm. C6, direct line from the anterior shoulder all the way down to the base of the thumb and then into the anterior and posterior thumb as well. C7, center of the palm to 2, 3, and fourth digits, and also posteriorly, center of the dorsum of the hand, 2, 3, and 4. C8, ulnar styloid across to the lateral aspect and to the tip of the fifth digit, and T1, 2/3 to 2/3. 2/3 of the way down the medial humerus to 2/3 of the way down the ulnar aspect of the forearm.
So what I'll talk you through now in terms of the dermatomes is how you actually do the tests. So we typically suggest using a piece of cotton wool. And hey James, how's it going? Using a piece of cotton wool and running through those dermatomes on the right side and the left side, asking the patient if it feels the same on both sides. You're then looking to see if there's a difference. Can you ascertain from your patient how much of a difference? And we like to try and use percentage terms. So for example, for your C4, if it feels 100% on this side, what percentage would you say on that side? And your patient might say 50%. Okay, great. We know it's 50%. So you can then write that in your notes, which is really important because, of course, you can then compare it in future sessions to see if the sensation has improved. One quick note, we were talking about the clearing earlier, and we were talking about consider spreading a neuro and why you would want to do a neuro upper limb assessment with your patient. And I said I'm going to come back to telling you where to find that information. So if you, again, on clinicalphysio.com, this time it's in clinical reasoning. So the clinical reasoning section, and if you scroll down to clearing tests, and then if you jump straight to, I think it's 5 minutes 15 or 5 minutes 14, the video will be me starting to talk about consider spreading a neuro. So you can go through that section to go through again if you want to why and when and to complete a neurological assessment. Okay, so we've done our myotomes and we've done our dermatomes. Next, reflexes. All right, so there's 3 key upper limb reflexes that you're going to go through with your patient, and then there's 2 maybes. All right, so the 3 reflexes that we're definitely going to do are the triceps, the biceps reflex, and the brachioradialis reflex. So it's triceps, biceps, and brachioradialis. And we're going to test these on both the right and the left sides so that we can compare the 2. All right, so how do you do your, I'm going to use a pen, but of course don't use a pen in practice, use a reflex hammer. So how do you do your reflex tests? Well, if you go to the, this is for the triceps first of all, so if you go to the olecranon, you'll go a fraction more proximally and you'll feel a little dip, and that dip is where your triceps tendon sits in. All right, so you're going to cradle your patient's arm, so their arm is going to be cradled, and you're going to tap in that area 3 times. Now, you're not just going to do a tap and hit like that, you're going to do a bounce. And the reason we do a bounce is it provides a more consistent reflex experience. So, and we're going to do 3 times, and it's always 3 times because you're trying to find an average reflex response. All right, and the spinal level that is tested with the triceps reflex is C7, C8. All right, so one way you can do it is testing it like that, and the other way is simply getting your patient to put their arm by their side, and then you test it on the back. If you want a better way of finding out exactly the handling and things like that, you've guessed it, clinicalphysio.com, videos, cervical spine, upper limb reflexes, and we go through the method of how to test it and the C7, C8 spinal level. So that's the triceps. The biceps. So very simply for this one, you ask the patient to flex their elbow, and you can ask them to flex it against resistance to start with so that you can actually palpate the distal biceps tendon. So if you ask your patient to if you resist your patient's elbow flexion, you'll be able to feel the distal biceps tendon, and that's how you know where to provide your reflex. Okay, and you again, we're going to cradle our patient's arm, and we're going to do our 3 bouncing taps, 1, 2, 3, compare right and left to have a look at the reflex. The reflex is there, and the spinal level, which is examined with the biceps reflex, is C5, C6. Okay, that's biceps, C5, C6. Finally, the other key reflex that we're going to look at is the brachioradialis reflex. Okay, now in order to find your point for this, you find the radial styloid at the distal end of the radius. Good question, Jordan, I'll come back to you. The distal radius, you're then going to come 1 thumb width proximally to that. So you find your distal radius 1 thumb width more proximately, and that provides the point that you're going to tap. All right, and you're going to do your reflex tap like this, and you won't find an upward movement. If anything, you'll find a little bit of a turn like this. That's how your patient will respond, with a little bit of a turn of the brachioradialis reflex. And the spinal level tested with this one is C6, C7. Now, you might find in some books some text, some articles that varies a little bit. It's very concrete that it's triceps C7, C8. It's very concrete that it's biceps C5, C6. Some people have variations for brachioradialis, but we always teach it as C6, C7. So once again, brachioradialis, C6, C7. How close to the insertion do you hit the tendon with the hammer? Not quite at the insertion. You're always looking for the gap. So if, for example, you're looking at the biceps, the triceps tendon, which will insert into the olecranon, you're not going to hit the olecranon. You're going to come into the gap between it. All right. So you're going to go to the olecranon and then one thumb width up effectively. And it's the same for the biceps. You're going to come a little bit more just proximally to where you can see it, so that you're hitting the tendon rather than the tendon insertion. And I think the best way of describing this is the Achilles reflex, because when you're doing the Achilles for the lower limb, you definitely don't hit the heel. You hit a little bit more proximally so that you make sure you're actually hitting the tendon rather than the heel. But I suppose in answer to your question, how close to the insertion, I'd probably say for the variety of them, maybe 0.5 centimetre to 1 centimetre. That's a rough guide, Jordan. You're basically looking, make sure you're definitely hitting the tendon, not the point that it inserts into on the bone. So those are the 3 key reflexes that you're definitely going to test. The other maybe reflexes are your Babinski and your Clonus, which are for testing for signs of an upper motor neuron lesion. So an upper motor neuron lesion is basically a lesion on the upper motor neurons, which is from the brain down to the bottom of the spinal cord. So, for example, possibility of a stroke, possibility of multiple sclerosis, possibility of MND, something that's a lesion that's causing a pathology in the upper motor neurons of the body, so the brain down to the bottom of the spinal cord. Okay. Babinski and Clonus, best ways of me teaching you that, have a look at the video. I'm going to talk briefly about interpreting reflex tests. So, by the way, clinicalphysio.com, cervical spine, you can actually go through how to test the reflexes. But we also have a separate video, which is really useful, and lots of people have commented on that it's been really useful for them, which is under the clinical reasoning section, called Interpretation of Reflex Tests. Okay, so that's under the clinical reasoning section, and it's called Interpretation of Reflex Tests. And guess what? It talks you through how to interpret your reflexes. Okay, it talks about the 4 possible results of your reflex test response, which is hyperreflexive, i.e. exaggerated response, normal, hyporeflexive, i.e. a little response. Remember, hypo is low. So hyporeflexive means a low response or a small response, or absent. Okay, and that video takes you through going through your classification for what each response actually means. Now, what you're effectively looking for is to see the comparison of the reflexes on the right side and the left side. If your patient, for example, has left-sided symptoms, and the right-sided reflexes are all normal and brisk, and the left-sided reflexes, whether it be one of them or all 3 of them, are hyporeflexive or absent, then you've clearly determined that there is a reflex, a lack of reflex response on that left side. So that's definitely something you need to note down and take it to your senior. What might it show? It's basically showing you signs of neural pathology. In most cases, it's along the lines of a neural compression. Very commonly, if it's including reflexes, then it's going to be the nerve root that is irritated. Now, if you've got both-sided, so you've got right and left-sided which are absent, that's a problem. All right, that's definitely something you need to look out for. And it might be that either you've got both the right-sided and left-sided nerve roots being compressed at one individual level. So let's say that you've gone through your testing and the brachioradialis reflex is pretty good and the biceps reflex is really good. You know that C5, C6 is okay, because those spinal levels have been tested with the reflexes and they've come out fine. That's good. But then you test the triceps reflex, which looks at C7, C8, and that's really lacking. You therefore might infer from that that there is a pathology at the spinal levels C7 or C8. Okay, now if it's just one-sided and there's a hyporeflexive or an absent reflex on just the left side, it might tell you that it's just left-sided C7/C8 pathology. Okay, what if it's both-sided? Well, that could either tell you that both the right and left-sided C7/C8 nerve roots are compressed, which is unlike, well, it's possible, but I suppose the more likely thing to look out for is a central pathology, i.e. something that is affecting directly the spinal cord at C7/C8, rather than something affecting the nerve roots on both sides. Please give me a wave or a thumbs up if that makes sense, or if anyone wants me to explain that again, I'll happily do so. But that's effectively the reasoning why you're looking at your reflex tests, to see if there's a difference between one side and the other. Okay, right. I'll mention one more time that if you want to have a look at reflex testing in more detail, you can either go to clinicalphysio.com, videos, cervical spine, and it takes you through the actual reflex tests themselves and how you test it and the handling. Or you can go to www.clinicalphysio.com, videos, clinical reasoning, and then there's a video called Interpretation of Reflex Tests, which is how you can look at the actual interpretation of the results in more detail. Thank you very much for the thumbs up, everyone. It's good to see that I make sense to you. So thank you very much. Right, so we've done we've talked about our cervical spine assessment. We've talked about our myotomes. You've very kindly looked at dermatomes, and we've talked about reflexes. No, Jordan, you're not wrong with myelopathy. It is, it is to do with compression of the spinal cord in particular. There can be different reasons for it. It could be a tumour, for example, which is one of the key reasons for myelopathy. So yeah, you can have a look at that in more detail if you want. And so the final part of our neuro assessment is our upper limb tension test, which I'll talk to you about in a second. But first of all, I've just remembered that we've also got to talk about the subjective part of a neuro assessment, which of course there is a subjective science, and that is asking our 5Ds and our 3Ns. All right. So the 5Ds and the 3Ns. So we're asking these questions subjectively to look for signs of an upper motor, not an upper motor, we're looking for signs of red flag pathology for the upper limb and the cervical spine in particular, which we would classify as things like VBI, vertebrobacillar insufficiency, CAD, which is cervical artery dysfunction, something like cancer, or signs of an upper motor neuron lesion, or something like a stroke. All right, so the 5Ds. So the 5Ds are dysphagia, which is asking your patient if they've got any problems with swallowing. Dysarthria, which is asking if they've got any problems with speech, and in particular it's the formulation of speech, that your patient is saying muddled phrases or jumbled words and things don't make sense. Also, the other Ds are dizziness, double vision, aka diplopia, or drop attacks. All right. The 3Ns, numbness, nausea, and nystagmus. Now, nystagmus is where the eyes do rapid side-to-side movement. All right, so those are your 5Ds and your 3Ns. Right, so let's go on to upper limb tension tests. So there are 4 upper limb tension tests, which stupidly are not called 1, 2, 3, 4. They're called 1, 2A, 2B, and 3. Okay? For the actual process of testing them, I would certainly like to ask you to look at the video on clinicalphysio.com, videos, cervical spine, upper limb tension tests. That's not a cop-out. The reason I'm asking you to do that is because it so much more clearly goes through the exact positioning of the arm that you're using for each individual test, and crucially the therapist position and handling, because the keys to performing the test is thinking, right, where am I standing and what am I pushing against? Reason being, for example, let's briefly talk about upper limb tension test 1, which is for the median nerve. Okay, the process for going through this is depression of the shoulder girdle, abduction of the shoulder to 90, supination of the forearm, extending the wrist, laterally rotating the shoulder and extending the elbow. Now, and that's in an abduction position. You can just see that that's convoluted, especially if you're having to hold the patient's arm through the whole of that. So the best way of I would suggest teaching you is you have a look at the video, because it clearly takes you through the handling, the positioning, etc. All right. What I will do is talk you through what each of the tests actually looks at and the process by which we do them. Okay. So upper limb tension test 1 looks at the median nerve. Upper limb tension test 2A also looks at the median nerve. Upper limb tension test 2B is for the radial nerve, and upper limb tension test 3 is for the ulnar nerve. Okay. So you'll see on the video when you go through it at clinicalphysio.com that the idea is that with the tension tests, you're going through a process of gradually increasing the sensitivity. You're gradually sensitizing each individual nerve as you do your tests. Okay, and the idea being is that you're looking to see that as you gradually sensitize it, as you gradually wind it up, do you create neural tension? Which is why it's called upper limb tension test. You're creating neural tension. Now, some of the key things behind this is, number 1, when you're doing a tension test, you're looking to reproduce your patient's symptoms. Okay, so you're looking to reproduce what they've told you in your subjective assessment. So if they said they get a shooting pain through their forearm, you're looking to reproduce that with your tests. Okay, if they get a shooting pain in the forearm and all you gain from the upper limb tension test is some shoulder pain, that's not reproducing your patient's symptoms. So you therefore wouldn't necessarily note that your patient's symptoms are down to neural tension. However, if they have that anterior forearm pain, and you have elicited it during your tension test, you can clearly say that their symptoms could be down to neural tension, because that's what you've tested and that's how you've reproduced their symptoms. Okay, now you'll find with lots of people, me included, if you go through tension tests with me, you will create neural tension, but I don't actually have any symptoms of neural tension. Thankfully, I haven't got any arm pain, I haven't got any pins and needles, I haven't got any numbness. Okay, so you can reproduce it in someone who doesn't have those symptoms, but the key is that you're looking to reproduce symptoms that they have genuinely told you in the subjective assessment. Okay, so that's key. So that's number 1. Number 2, when you are going through your upper limb tension test, you'll commonly see that in some textbooks they talk about positioning the arm and then taking the cervical spine into a side flex position away from that arm. Okay? We don't like to teach it that way. And the reason being is because when you're doing that with your patient, you'll put them in that position and you're holding their arm and you've got their arm against your hip and you're saying, okay, can you just take your neck out to the side, and they'll go into rotation. You're saying, no, not that way, this way. And they'll go, that way? No, this way. And it all gets lost. So what we teach you on the videos is before you've even touched their arm, position your patient's head in side flexion away. That's the first thing you do. And the reason being is that you can position their head from the start knowing that it's in the right position rather than going through all your tests and then finding that they don't know what they're doing. So countless times I've gone through the whole test and then said, turn your head away, and they say, I don't get it, and I've had to drop the whole arm, show them what to do and start again. All right, so don't make that mistake. Okay, thirdly, let's talk about interpreting results with your upper limb neural tension tests. So you're looking to try and reproduce your patient's symptoms, okay, by going through the process of gradually sensitizing their nerve through the arm and then checking whether or not there's a cervical spine component to it. So let me explain that. So with your upper limb tension test 3, you're effectively getting your patient in this position for the ulnar nerve. Okay, so let's say that our that our patient's head is here in cervical spine side flexion, and we've put our patient in this position, and we've generated their symptoms. We've generated neural tension. Okay. What we're then going to do, we know we've got neural tension. What we're going to ask them to do is take their cervical spine from this position back to the neutral. Okay. And we're going to see if their neural tension changes when we do that. Okay. If it does change, we've highlighted that with cervical spine stressing, they've generated their symptoms. And when we loosened the cervical spine, the symptoms went away. So that shows us that there is a cervical spine component to the patient's neural tension. Okay? Because when we changed the cervical spine position, their symptoms got better. So that shows us that the cervical spine is sensitizing their symptoms. Lots of people in the past often think that if you take the head back to the middle and the symptoms go away, that there's no neural tension. That's incorrect. You've already demonstrated, you've reproduced their symptoms, you've demonstrated there is neural tension. There is neural tension. What we're now trying to determine is that neural tension down to the cervical spine or due to a compression or an irritation more distally in the arm. Okay, so the way we do that, we've created the tension, we then take their cervical spine from side flexion back to neutral. If the symptoms got better, that tells us that there's a cervical spine component because it got better when we de-stress the cervical spine. If their symptoms do not get better, so let's say here to here is exactly the same, that simply tells us that the neural compression and the tension is not being created at the cervical spine, and instead it's being created further down the arm peripherally because we haven't changed the arm position and the patient's symptoms are still there. Okay. Now, if you want to, you can go through the process of kind of desensitizing by taking the elbow away and taking the arm away to see where the tension might lie. But effectively, to keep it simple, the key thing you need to check with that, if you've reproduced your patient's symptoms, is de-stress the cervical spine and see if their symptoms improve. And I hope I've made that clear. Tonight, just to clarify, we've gone through, first of all, why you go through a upper limb cervical spine neurological assessment, which is part of your consider spreading a neuro phrase that we said. If that doesn't make sense, clinicalphysio.com, videos, clinical reasoning, clearing tests, and go to 5 minutes 14 and you'll get the information about consider spreading a neuro. We've gone through the myotomes, we've gone through the dermatomes, we've gone through the reflex tests, and we've gone through your upper limb tension tests, and we briefly talked about the 5Ds and the 3Ns as part of your assessment. So I really hope that's helpful. Thank you so much. I can see so many people flooding in and saying thank you very much for going through it, but at the same time, thank you so much for joining in, because this wouldn't be the same without you guys on and sharing the experience with us. So thank you so much.